welcome everyone. I hope you're joining us from Facebook. We are live and we have an excellent program for you this evening on the disparities in headache and migraine care for the Black community. It's something that we all need to learn about, and it doesn't matter where you fit into the community in terms of color. We are really broadcasting this out to the entire BIPOC community. And we just want to wait another moment till we maybe get a few more people, although I do see a good number of people on here. So I want to start by welcoming you. I am Shirley Kessel, and I'm the Executive Director at Miles for Migraine, and I'm proud and excited that we are able to put this program on this evening. This is something that we've been trying to do for many years, and here we are. So I just want to give you a little backstory. So the entire migraine and headache community has been working for the past 2 years on a project called DIHAC, which stands for Disparities in Headache Advisory Council. The link, I'm going to put it on chat right now. It's about to go, it'll go onto Facebook as well if you want to learn more about DIHAC. And this is actually a program of CHAMP, which is the Coalition for Headache and Migraine Patients. And we put this together because as a community, we were aware that the BIPOC population, which BIPOC stands for Black, Indigenous, and People of Color, is underrepresented in our space. So in 2020, DIHAC, which is part of CHAMP, hosted a cross-cultural competency training series for its members and continued to host frequent webinars with guest presentations from leaders of effective disparity reduction campaigns in other disease areas. In early 2021, the Council reviewed and approved 6 proposals for new initiatives that will diversify the engaged headache patient community and reduce health disparities in headache medicine. Miles for Migraine has been participating in these training sessions and is also the recipient of one of these grants, and that is why we are bringing you this program today. We are also proud to announce, and we want to invite you, that we will be hosting a brunch following the Walk, Run, Relax event in Philadelphia on October 1st. That will be a continuation of today's conversation featuring a prominent Black physician, Dr. Courtney White from Jefferson. And you can register to join us. The brunch is free. If you would like to just join the brunch, you are also, of course, welcome to come to the Walk, Run, Relax. We will actually be having some other free programming going on that day. We will have a family fun zone, which will have a lot of fun games for young folks, and we'll be giving away free prizes. So, and we also have a treasure hunt that you can come and take part in. So please check it out after today's meeting, and let's get started. I'm going to turn over the podium here to Dr. Annikah Salim.
Thank you, Shirley. Hi, everyone. We are very excited that you all have joined us here this evening for this very important talk. I'm very happy to be here and to host and moderate our discussion this evening. I'll introduce myself and then I'll introduce the others who will be joining me as we talk a little bit more about migraine and headache disease. So as Shirley mentioned, I'm Dr. Annikah Salim. I am a person who currently lives with chronic migraine with aura and occipital neuralgia. I'm also a patient advocate. I'm involved with Miles for Migraine as a support group leader, and more recently, I joined as a project manager working on our chapter expansion outreach program. So that's a little bit about me. And just to move us into the discussion, not everyone realizes that migraine is a misunderstood and misdiagnosed disease for many people, but is especially prevalent in the Black community. And it's misunderstood and misdiagnosed due to racism and mistreatment that we have faced throughout history. And that's why we are excited to be here today and have this conversation and talk about what migraine is and how can we get diagnosed. So today I am joined by a patient advocate, Grace Chappell, and also a physician, uh, Dr. Teshamae Monteith, who specializes in headache and migraine medicine. Thank you both so much for joining us for this discussion. Grace is a new member to our community and lives with hemiplegic migraine and chronic daily migraine. And Dr. Monteith is an associate professor of clinical neurology at the University of Miami, Miller School of Medicine, and she is the chief of the headache division and the program director for the United Council of Neurologic Subspecialties Headache Medicine Fellowship Program. Welcome, Grace, and welcome, Dr. Monteith.
Thank you for having us.
Thank you.
Okay, I will kick off this panel discussion with Grace. If you don't mind, would you share with us your story about migraine, your migraine diagnosis, and how you came to get diagnosed?
Again, my name is Grace Chappell. Hello, everyone. My migraines, I was diagnosed in 2015, which was a misdiagnosis from 2007. It took me continuously to go to my primary care physician and being misdiagnosed. Primary care physician basically told me that maybe is what I'm eating because I continuously to keep having frequent headaches. And I just couldn't shake the pain. Again, going to the primary care physician, asking them and explaining to them exactly what I'm going through. Again, it was, hey, what are you eating? Oh, you should change your diet. Maybe it's high blood pressure. Does it run in your family? And none of that was, current and true in my situation. So again, continuously to keep going back. When I finally got a good primary care physician, because the office that I went to, you saw someone different. I finally had someone that was more frequent and I began to build a relationship with. She actually referred me to a neurologist, and that's when I got diagnosed. But it was from 2007 all the way up into 2015 that I had to live with migraines. Well, actually headaches, because it wasn't diagnosed yet until 2015 as a migraine.
Wow, that sounds very similar to my story, Grace. Just growing up as a child, going to the hospital and emergency room consistently, just from what I can remember. And that was pretty young, like around 7 or 8. It could have been soon before then. I just don't recall. Up until adulthood. And like you, I was not diagnosed until 2015 with migraine. And I was told, just take something over the counter. It's a headache and all of these other things that were related to migraine. Just they seemed so isolated. But as I came to learn my diagnosis, I understood it was all migraine. So I think those are some similar stories many patients have. Dr. Monteith, so as we've been talking about this misdiagnosis and going to doctors and being told that it's something other than what we're actually, the condition we actually have, can you share with us what migraine is? What causes migraine? How do people know they have it? And then how do we get diagnosed?
Yes, so that's a great question. Migraine is a primary headache disorder. So there are primary headache disorders and secondary headache disorders. Secondary headache disorders are caused by other things, so they're secondary. Migraine is the most disabling type of headache in people 50 years of age or less, in women 50 years of age and less, and second overall. So it's a chronic neurologic disorder defined by oftentimes recurrent headache and other associated symptoms such as sensitivity to light and sound, nausea and vomiting. It can be, and we can talk about the symptoms of it, but it's the best way to think of it is as a neurologic problem that can be triggered by sometimes environmental factors, sometimes without any known trigger. So the primary care doctor, I think, did an okay job by asking you about your diet, asking about other secondary things, but it's important to go beyond that, right? Not just that initial evaluation, but once you recognize it's a migraine, really treat it as such, because the treatment can be a very specific treatment to reduce disability.
So Dr. Monteith, when you talk about this migraine being a neurologic disorder, is it safe to say that it's not something that comes and goes, migraine itself? Or is it that the symptoms come and go, triggers change? How would you actually say, like, how would someone who doesn't live with migraine understand exactly how it manifests in the
Well,
body?
that's a great question. The best way to think about migraine is as a brain state. So it's a genetic disorder. Most of the times you can find someone in your family that has it. So there's a wiring that predisposes you to have migraine attacks. And it is an episodic disorder for most people. And it can be triggered by things. So triggers can change, physiology can change. As I said, sometimes you don't find that trigger, but migraine is in some ways always happening. The brain connections of people with migraine or the functional changes associated with migraine are different than people that don't have migraine. So we know that migraine is always happening. There's a brain state and there's a vulnerability for having migraine attacks.
Thank you. Thank you. And while we're talking, everyone, start thinking about other questions you might have that you want to ask our panel. If you're in the Zoom, feel free to put questions in the chat. Same for those who are on Facebook Live, we want to hear from you as well. And as we facilitate this discussion, think about some of the questions you may have or someone you may know or be in contact with who may be going through this condition and how you can support them. So Dr. Monteith, one more question before we go back over to Grace. Grace, I did want to ask, like, can you tell us that there appears to be over 300 classifications of headache? You talk about primary and secondary. Can you talk a little bit more about all of these classifications and go a little bit deeper into how we can understand that better?
Yes, so the classification is a symptom-based way of classifying different types of headache disorders. And we can look at that, but the classification system is actually called the International Classification of Headache Disorders. It's now in its 3rd edition, so it's been going on the process for 30 years. Pretty soon there will be a 4th edition that's available. And you can look at the International Classification of Headache Disorders. It's actually pretty interesting. It's free to the public. So I can put that in the chat for you to take a look at, but it's divided into primary headache disorders, secondary headache disorders, cranial neuralgias like trigeminal neuralgia, occipital neuralgia, which is something that you have. And then the appendix means we're trying to still sort that out. We need more research to validate this as a diagnosis. So, but most people are going to fall into the category of primary headache disorders. Secondary headache disorders are the things you want to rule out, you know, because they're reversible, potentially reversible, or sometimes life-threatening things like meningitis, encephalitis, HIV that can cause headache. And so for the primary headache disorders, the most common actually primary headache disorder is tension type headache. It's rare that patients with tension type headache seek a doctor. So oftentimes patients get misdiagnosed as having tension type headache. We know in the African American community that they have high rates of misdiagnosis. So sometimes being diagnosed with tension type headache means that you don't get the right treatment that you need because the headache is considered something that might be mild or that can be treated over the counter. So tension type headache, migraine, and there are different subtypes of migraine. There's migraine with aura, most commonly visual disturbances, but people can look like they're having a stroke with a migraine with aura episode. There's chronic migraine, 15 headache days out of a month or more for at least 3 months. 8 of those days are generally moderate to severe. And there are many people that have chronic migraine for decades long and have tried multiple treatments. In the overall population, it's about 2% that have chronic migraine. So 2 in 100, and about 9% of all patients with migraine. So it's not an uncommon thing, chronic migraine, and it tends to be the diagnosis we see a lot in our clinics. There's other types of headaches. People have headaches associated with sexual activity, or headaches associated with physical activity or exercise-induced types of headaches. So these are things that can prevent you from functioning. There are other types of headaches that are associated with abdominal. They present mainly with abdominal pain and abdominal discomfort, but it's a precursor to migraine. And so there are many different types of migraine and other primary headache disorders. The main thing that the doctor has to worry about is making sure that this is not a secondary headache. But once you figure it out, this is not a secondary headache, it's really important to try and get that treatment for migraine, which is preventive and acute. When you're having an acute attack, it's not just drugs, but they're lifestyle interventions, and there are even devices and newer ways to treat migraine.
Yes, thank you. And it's we were talking about the I just recently got diagnosed with occipital neuralgia. As we mentioned, Grace and I were diagnosed roughly around the same time. And that was my diagnosis, was chronic migraine with aura. But I didn't get diagnosed with occipital neuralgia until last year. And having that diagnosis really helped improve the severity of my attacks. But it's constantly learning. And you mentioned all of these classifications of headache and how they manifest, what they look like. And I feel like I'm constantly learning. Even today, some of the things you shared, I just learned. So for me as a patient, it definitely changed. It was important for me to learn about my diagnosis. And Grace, for you, I'm interested to know how you learned more about migraine following your diagnosis, and how did what you learned help you feel empowered and lead you to become an advocate?
The piggyback off of you guys, just basically I deal with chronic migraines, a daily chronic migraines. I have one now. It doesn't go away. I might look one way, but of course, migraines are an invisible disease that no one sees. Far as being diagnosed, again, me researching, not only just going to having this newfound diagnosis and going to the neurologist. Of course, there were like trial and error going to the neurologist, being treated with different medications, making sure that this one was right for me. I actually got on a regimen that was good until last year. I was diagnosed with hemiplegic migraines. It presented as a stroke. Everything, my whole left side, my speech. I was actually paralyzed on one side. It's a temporarily paralyzation. I can't, there's a brain fog. It makes it difficult for me to think. Again, it was a scary situation. And then just doing the research of these hemiplegic migraines, because I did not know exactly what was going on. And me actually not sitting in that just made me want to speak up, because again, we could take a lot for granted far as our speech, our talking, the things that we do, because of these disabilities or disabilities that we actually been diagnosed with. And again, just doing the research, and not always allowing a doctor to tell you it's one thing. Sometimes we have to advocate for ourselves, because if we don't, no one else will. So again, just me being a part of Miles for Migraine and just advocating for myself and others as well. It's something that this hemiplegic actually migraine have forced me to do so.
Yeah, it's important to advocate, not just in when it comes to our medical care, but also in social settings. So, we have to help. I had to learn to educate the people around me, in addition to educating myself, because it was something new for me. Learning about migraine, or thinking, I came in thinking, oh, a headache can't cause me to lose my vision. A headache can't cause me to, like, you have temporary paralysis. Like, I did not understand that. So learning more about it was important. But then now I had to, like you said, migraine is an invisible disease that no one really sees. So now I have to explain why I look okay, but I feel extremely debilitated. So like you said, it's very important. That advocacy is extremely important. Dr. Monteith, you talked about some of the statistics around migraine and headache disease. Are there any differences in the way Black or African Americans experience migraine versus those who are not in that population?
Yeah, before we get to that, I just kind of want to emphasize what you said, that how can a headache cause you to lose vision and cause you to have weakness on one side or hemiparesis. And it's not the headache, it's the migraine, right? Which we said is a neurologic disorder. So it's not just a pain driven symptom, it's a whole brain dysfunction. And so I think that's what people have to really understand, that it's more than just a headache, right? And in terms of the prevalence of migraine, while African Americans don't have the highest rates of prevalence of migraine, they do have more severe migraine, at least according to some studies, more severe migraine and more disabling migraine. There are some symptoms like allodynia that are more associated with more severe headaches that have been shown in African American communities. And so the prevalence is too high in any population. But I think the issue is that the undertreatment and the severity and the access.
So I want to switch over to Grace as we, you know, continue on this line of conversation. So Grace, from the patient perspective, what do you think? Will you talk a little bit more about the disparities as a patient in migraine and why you think you may feel like Blacks or African Americans are conditioned to not ask for help? Um, how the community lacks access, as Dr. Monteith just mentioned, the inability to access care. And sometimes I know for me, like I have this idea, like I'm just going to push through. Why do you think we have that pattern of thought when it comes to specifically this condition?
From experience, I believe just not being heard. Again, the relationship between the provider and the patient, there's not a great relationship at times. Again, we express stuff as patients, but sometimes the provider doesn't hear us or listen to us, and they just put us off that, hey, everyone comes in here like this, or you all want to, they put us in a group and think that, hey, if I come to the emergency room and I'm in pain, oh, everyone wants medication, or every Black person wants medication. We just want to be helped just as well as our other counterparts. Again, there is times where I just think that it's just a communication and a relationship. And the reason why sometimes, again, we have to push through because we're not being heard as patients. Especially, it's so many disparities that we already have to face. Is one, I have a migraine, which is an invisible disease. Second, I'm African American, and they think that all African American people have this, we're strong, we can push through, we don't need help. Oh, you'll get over it, you strong. But sometimes, hey, we all are weak in some ways. We need help. And it's nothing wrong for that. And again, being pushed away consistently kind of, I know for a lot of people, just make them uncomfortable even going to the doctors because, again, not being heard several times or being talked about or being misdiagnosed. And then it could be the way you look, the way you dress. So particularly you go to the emergency room, you try to not have sweats on, you try to dress up so they can actually take you seriously versus I got something that's making me feel comfortable, but I'm still uncomfortable being uncomfortable, so it's not a win. It's just us wanting to be heard and be treated equally and fair.
Yeah, if I might add, Grace, sometimes when we feel there's already going to be a bias, when you think about living with this condition, as Dr. Monteith mentioned, some of the manifestations like that sensitivity to light, right? The loss of feeling, the inability to speak clearly, like you mentioned, the brain fog. This is outside of the pain, right? Sometimes, and to think if we have the perception that we're not going to be seen or not going to be heard, why go through the effort of putting yourself through all of the being uncomfortable, even sitting in an emergency room with these bright lights and noise and having to drive or maybe get someone to drive you if you can't see well enough, or if you're in pain, just to get dressed only to be treated or dismissed, and why bother? So that's also that component of not even getting to the doctor. to be seen. And so there's a lot of reasons why the community may not have that access. And Dr. Monteith, from the physician perspective, what do you see as the barriers to Blacks or African Americans accessing care that other populations may not necessarily face?
Yeah. Well, I have to say that access to care for headache is a huge problem. No matter who you are, what you are, I don't care if you're like the Biden's child or whatever president's child, or it's going to be hard for you to get in to see a provider just because the sheer number of headache specialists to the population. So, being able to know where to go, have those resources to find a good provider and to be able to ask your provider, who do they recommend for migraine care? Not every neurologist manages migraine. Some of them specialize in other conditions, and some of them will be willing to work up the patient to make sure it's not something severe or something secondary, as we mentioned, but don't necessarily go on to treat the patient, at least in an aggressive way, for sometimes a long-term situation. So it's important to have resources to access care, and once you do that, then also to be a co-participant in the relationship, follow up. There's been studies showing that African Americans are less likely to follow up with their care or to continue their medications, which can be a problem again for migraine in general, but in particular African Americans. So feeling that you can trust your provider, and what are ways that you can facilitate that trustful relationship. It goes both ways, right? And even with the staff. And so how can you participate and drive that care and drive that partnership? And then if you don't feel like you're getting the results you need, you have to have the resources to go somewhere else. And with telemedicine, I have to say that now you can generally go statewide to find a provider. And so it's nice. This is a good time to be a migraine patient.
So, Grace, I wanted to ask you, you mentioned, Dr. Monteith just mentioned about knowing how to facilitate that conversation and relationship with your doctors and building that trust. Do you have any advice or recommendations or suggestions in your experience from the time that you talked about, seeing your PCP a number of times and not getting that diagnosis? As you've grown and learned, do you have any thoughts or ways that we can speak to our providers and try to get, a quicker diagnosis, or ways that you've experienced that you felt that now as you speak, you're actually being heard by your doctor?
Again, I would basically just say, just advocate. Again, I did give up during those times when I first got diagnosed. I thought that, hey, let me take Excedrin because they're not hearing me. Maybe this will be my best friend. Sometimes, what work, family, so sometimes we put ourselves on a back burner and our health on a back burner because we feel like we have so many other things to take care of than continuously to keep going back and forth to the doctors. But I will say, learning, I could have probably pushed or got a second opinion. I didn't have to just give up and just take what they said. Again, just always advocate for yourself. If you know something is not right, you know your own body. Can no doctor or no one else tell you how you feel, even if they don't believe you, even if they continuously keep turning you away, you know your body and don't take no for an answer. So that's what I would say. That's exactly what I did. Again, I don't know if I could have avoided the hemiplegic migraines coming on if I would have gotten care sooner. I don't know. Sometimes I think of it that maybe if I would have gotten the earlier diagnosis, I wouldn't be dealing with the hemiplegic migraines. But who knows? My fate, who knows? But I will say, me having this, I won't take it as as something that a loss. I would take it as a gain, even though it's painful. I would say that it actually got me to where I'm at now to speak up, to actually say I have to advocate for myself because no one is not actually have friends or family and loved ones to help you along through it. Talk to someone. Don't always think that you can just do it by yourself. We all need help in some form of way. So exactly, that's what I would say. Again, if no one else is going to advocate for you like you.
Yeah, I think that's so important. And I think that applies to everyone, regardless of what population you're in. We have to advocate for ourselves. We have to stand up for ourselves. And, it's important to realize that, like you said, we know our bodies, and sometimes no one believes us, but you have to keep pushing. And I know, like, especially living with migraine, it can be exhausting. It can definitely be exhausting, but that's why I think these conversations are so important. And I think it's poignant for us to participate in these, because like you, sometimes I feel like, would I have ever become chronic if I had gotten diagnosed or treated sooner than in my 20s, you know? And I wonder, but for me, I don't dwell on that. What I do now is keep having these talks so that someone else can hear and recognize and learn and know, so that maybe they can get help sooner, or they can help someone else that they care about, or their loved ones can get help sooner. Um, so I agree with you. And something that you said, Grace, I wanted to pose a question to Dr. Monteith. Grace mentioned that, there's times when we just put our health care on the back burner, our medical care on the back burner. How do we get this community to prioritize our health care, since there's so many other chronic conditions that come first, right? Grace mentioned that, she was asked about high blood pressure. So we have like other prevalent conditions in the community, like diabetes and hypertension and things like that. And if we feel like, oh, I just have a headache, I'll deal with it. When it, like you said, it's not just a headache. So how do we not put our health care on the back burner and really make looking at migraine and headache disease as just as important as these other chronic conditions?
Yeah, I think it's important to educate. It's all about education, because if you think it's just a headache, you're going to go on taking something over the counter, it's not working. You're going to normalize not going to work, or going to work, showing up, your eyes are open, but your brain is not functioning because of the pain. And so I think it's important to educate your friends, your family members, let people know that if they're saying that they really have a bad headache, they just need a moment, or they're a little bit irritable with you because you're talking too loud. And usually they're okay when you talk really loud, when you're gossiping. It's important to educate, and then to recognize that it's a preventable problem. And also to raise awareness that it's a disabling problem. Because now if you're a person that has a mild tension type headache, you take a little something over the counter and 20 minutes it's gone. We don't ever need to have that conversation. But if you're someone that's having an impact from these headaches that are have migraine qualities and symptoms and disability, and you're not able to, you're calling out, or you're missing out on your important social functions, or you're just not fully who you are, the energy and the vibrance that you normally have. Recognizing that it's preventable, and that there are many options. It's not just drugs, even though drugs can be very effective when they're high quality drugs, things that have been studied very well. And now we have a lot of safer, newer treatments to use. And so to recognize that there are many different treatment options, that it is disabling, and that it's impacting your quality of life, and that you could have a completely different existence.
Yes, I'm so glad you said that. And I kind of been, it's been challenging. I've been trying to peek at the questions popping up in the chat. And I know that people have been asking about treatments and things like that. And we definitely want to get to those questions. But Dr. Monteith, that is very important. I remember when I was before I got diagnosed, I had my first, I remember the day that I became chronic, because I remember the day that I always took over the counter and it did not work. And I did it for almost 4 days straight. And then I went to the ER, and for almost 11 months, I was debilitated. Did not go to work, did not go to school, did not go to church. The only time I left my house was to go to the doctor.
Right.
And I have a completely different experience now. I'm still chronic. I have an attack now. It's always there. But just that process of getting to this point, I remember one doctor in the hospital telling me, you will not always be like this. And I did not believe it, because it felt like it was never going to end. And I look at today that, yes, it can be different experience. And that's what Grace is saying about advocating and getting that support. And so I do have one question for each of you before I want to leave enough time, because I see there's questions in the chat and we want to make sure to get to those questions. So as we're talking about this advocacy and support, Grace, what was important for you about advocacy? And I know that you're really involved in Mouse for Migraine support groups. And what does that mean for you? Why did you join? And what words can you leave with others as those who are going through this condition or know someone who is?
I'm sorry. Sometimes, the fog brain happens. This is just a part of our life, migraine.
Yeah, that's okay.
But I will say, me being a part of Miles for Migraine, I actually was told by a family member, because again, you want to tell people exactly what you're going through. Again, I used to hide all the time and then did not want to share. I was such a private person. Like, no, you will not know what I'm going through because I can beat this. But it came a time where I couldn't by myself. I had no choice but to say something and help. I remember my cousin calling me like, Grace, turn on the news. They're talking about what you told me you had. And I logged in to the local news station. It was a panel of Miles for Migraine. And it was our fellow Miss Deb. I saw her talking about her migraines. And I said, oh my gosh, she looks like me. And that was something that I didn't think that it would happen. Just someone that looks like me on TV talking about their migraines, because again, we have to be strong. We can't show a weakness. And she gave me that, because looking at her just said, hey, I have to sign up. I have to figure out what this Miles for Migraine, even though it took me some time to actually do it, but I finally did it. It was a great experience. Again, I would say get support. The support groups are great. They're very understanding. They're very helpful, because you think that you're the only one that's going through what you're going through, and to find out that there are so many more people that's going through things, and you learn from one another. So again, that was important, to really see someone that, like me, be a lead of a group that's something that I was going through. So that really was amazing. And I would say, hey, everyone, sign up. Even if you sign up and you might not have migraines, you can, again, help someone, that your loved one or your friend that has migraines, and you can kind of like talk to them and educate them as well. And you get educated yourself. So again, I love it. I enjoy it. And again, if it wasn't for the hemiplegic migraines, I probably wouldn't be here. And I'm thankful for it. So yes.
Agree. I feel the same way about my group, Grace. When even on my worst days, most of the time, I rarely feel like it. Rarely feel like logging in, but every time, and most of the people in my group say the same, that we always feel better for some reason. Like, the pain doesn't go away, our symptoms don't go away, but we always feel better just being part of the group, because we encourage each other and we know that someone out there is just supporting us. And I feel the same way about the group. Dr. Monteith, now, when it comes to support, what are some ways the community can help, the church can help, other organizations can help those who live with migraine and headache?
Yes, I think support is a really important thing. And I think when it comes to the African American community, there's actually some increasing data that social support, such as churches, can actually make a therapeutic difference. And so that's been shown with other types of chronic disease, but I think it's also important for migraine. Again, I think it goes back to empathy, to listening, and then also trying to support each other. If someone can't make it to church, understand that sometimes church may be too loud for someone that has migraine. Standing up might be, it's not that they're not wanting to pray or be prayerful or express themselves, but it could be that they're exhausted. It could be that they have to slip out early because they have too much nausea and they don't want to puke up the place. So to allow people to to manage their migraines, how they need to manage their migraines is really, really important. That goes for many, many relationships, to hear, to be supportive. And sometimes, you know, just kind of having that community support. Maybe, you know, Lisa needs her to take her daughter to school, but she can't do it because she's a migraine. Well, that's what we have the community for, you know, trying to have some shared solutions. So I think all of these things, because migraine really just, you know, that is one important thing that you bring up indirectly, is that migraine affects the person, but the family, but also the community, right? Because if Laura can't go to choir practice, and let's say she's leading, and so that causes some disruption. And so we have to understand that it's not an excuse. This is a neurologic disorder, and but also, you know, help her find the treatment she needs. And, you know, places like Miles for Migraine is a wonderful place to start, because of all of those resources.
Thank you so much. I wish we had time to keep this discussion going tonight, but we do want to leave time for some questions. So Grace, thank you so much for sharing your story as a patient, and Dr. Monteith for sharing insights and educating us from the physician perspective. I did see some questions, so I will turn it over to Shirley. If we have questions from the Zoom or from Facebook, please.
Yeah, so Dr. Monteith, do you find patients have consistent symptoms, or depending on age or lifestyle, a patient migraine symptoms can evolve?
Oh, I mean, it's completely variable. There are people that have very consistent migraines. They know when their migraine's going to happen. It's always one-sided. And then many people have a variability. And then what can be really interesting is that some people undermine their migraines, even though they know they have it. They think they only get it 3 times or 4 times a month. And because their migraines lead them to the ER, they vomit. They think that the other headaches are not migraines, because no, migraines are when I'm really bad, but the ones where you're very bad but not really bad are also migraine too. And so it's the full spectrum that a migraine in the overall migraine in the population can vary. In the pediatric population, it could be shorter lasting. In older patients, it can slowly dissipate the headache phase over time. Sometimes they present with more neurologic symptoms. And so it's a complete variability.
Okay, thank you. Zion asked a couple of questions. I think she got some answers in the chat. But another question that was put in there was, the neurologist will not give me an MRI, and I've changed my diet and everything and nothing works. What do you think I should do next? Well, I think we may have answered that question, but can you just maybe reference as to why a doctor might not order an MRI, and is that reasonable?
Yeah. Well, the reason to order an MRI is really not to diagnose migraine. The reason to order an MRI is to look for something else that might be triggering pain that looks like migraine, but is not migraine. And so there are what we call red flags. These are warning signs that there's a secondary headache involved. And there are a number of them. There's a kind of a little acronym called SNOOP. But if you have neurologic symptoms, weakness, loss of vision, you have fever, you have a history of cancer or autoimmune disease, or you're immune competent, meaning that you have like HIV or something. These might be reasons to consider ordering an MRI if there's a secondary consideration that you have. But someone that has long-standing migraine and they get these attacks, and they can be severe, they can last a long time, but they're recurrent and they've been going on and they're generally stable but bothersome, does not need an MRI. The recommendation is not to order an MRI. And so the MRI is only to evaluate for a secondary disorder. Migraine is something that we can diagnose by the history, the physical examination, and the presentation.
Okay, thank you. I think, Annikah, there was a couple other questions maybe that you had.
I do. If there's no other questions, yes.
So I'm seeing a question in the chat here. It's a really good
maybe
question.
you can talk about, Dr. Monteith, can you talk about ID migraine?
Mhm.
And we actually have it on our website. If anybody's interested in going there, I'll put it in the chat, but maybe you can talk a little bit about the development and why patients might want to go check that out.
Yeah, so ID Migraine is a quick way, and it was built to distribute in primary care settings. It's a quick way to screen for migraine. And essentially, you're asking a patient whether they have headaches that are associated with sensitivity to light, nausea or vomiting, and some disability. And if they answer 2 out of 3, then that is quite sensitive for the diagnosis of migraine. So it's a quick screening measure. Um, no one measure is perfect, but if you have 2 out of those 3 symptoms, and it's recurrent, it's coming and goings, chances are good that you have migraine.
Okay, great, thank you. We have about 5 minutes left. Another question is, oh, if migraine has a large genetic component, why might one family member have episodic migraine and another have chronic migraine?
That's a fabulous question. I
Yeah,
see a
it is.
budding neuroscience/headache specialist. I don't care where you are in your training, you need to apply to medical school and help us sort this out. And so the genetics of migraine is extremely complicated. It takes a lot of patients with migraine and a lot of patients without migraine to compare them to then look for mostly what you're finding are these risk alleles. So these are risk factors for having migraine. And so they're not perfect. If you have this risk, you're definitely going to have migraine. And so because these population studies need to be very, very large for chronic migraine, when they've tried to look at the population of chronic migraine on a population level, they were not really able to find good genetics to support chronic migraine has an independent diagnosis. And that is likely because it's probably underpowered, or there were just not enough people in the study. We definitely need to learn a little bit more about chronic migraine, the genetics of chronic migraine, and much of it might be environmental.
Okay, interesting, environmental, okay. Um, let's see, there was another question. Do you, do you have any information, Dr. Monteith, about headache specialists in the pipeline? I mean, obviously, Miles for Migraine, we give grants to over 24 headache centers in the country to train new fellows. And, but in terms of that, have you heard anything in the community about how, I know, for example, AHS is working to get more doctors involved and interested. Anything else you might be able to say about that?
Yeah, so I'm not sure exactly what kind of question. So I think there's optimism in the field because we're constantly opening up new headache fellowships, which means more opportunities for people to train in headache. When I was a fellow, there were only 12 programs, and now they're close to 40 or 41 or something programs as of maybe. And so the numbers have really increased. And what's also important is not just the number of headache specialists, but the number of nurse practitioners that are becoming very interested in specialized in headache. It's not just having to go to a doctor, but there are nurse practitioners that are available. And there are primary care doctors that there are initiatives from the American Headache Society to teach primary care doctors to learn more about headache to better treat their patients.
Right.
And so, all of these things I think are promising.
Yes, and it is. And also the National Headache Foundation and the Association for Migraine Disorders are two other organizations that train other specialties that are not neurology. So hoping to make more change there. One other question is, can you talk a little bit more about why African American men should seek care and many of them don't? Maybe like even a little history around that as to why they don't and why should they?
Yeah, well, that's a great question. I think in general, men in general are less represented in headache clinics and, and probably in primary care clinics as well. And so women tend to present more and engage more in healthcare settings. And, so that becomes a particular problem with the African American community. And the African American community is a broad strokes, right? Whether you're a Northeasterner or South, or different components, but certainly studies certainly have shown that there's a level of mistrust, and some of that is historic, related to really horrible experimentation that has occurred decades ago, and some of these injustices that really just kind of medical racism. And so again, building that therapeutic relationship has sometimes may have challenges. And it has also been shown that African Americans tend to trust providers that look more like them. So the question you had before about the pipeline, it's really important to increase our diversity, equity, and inclusion initiatives so that we have more people that are African American that say, you know what, I want to go into headache. Headache is an interesting thing, and I want to be a neurologist and care for people, and be available for people of all colors and attributes. And so we certainly have a massive underrepresentation of African American headache specialists, which is just another layer of it. But I would say that men in general are less likely to access care, African Americans in particular. So some of this is a cultural thing, and some of this may have some historical roots as well. And then some of this is also the culture of migraine.
Right, absolutely. Thank you for sharing that. I think that's a really important aspect that everyone needs to understand. We have two other questions that are kind of somewhat related. And without offering any medical advice, obviously, Dr. Monteith, that's not what we're asking you to do tonight. If somebody has, intractable migraine, if their medication has stopped working, what do you think? Is that something that they should be inpatient for into the infusion center, or outpatient, or is there something more that, they should be talking with their provider about?
So I think that it's really important to, first of all, obviously making sure that that's not a bothersome problem, some type of secondary reason. Some people develop thyroid disorders or other endocrine disorders or other types of conditions that predisposes them to start having more headaches. And so, we know obesity is associated with more frequent and more severe headaches, for example. So, and then there are other types of headaches that are not migraine. Let's say you gain like 50 pounds within a period of 3 months during the pandemic. There are other conditions, one condition in particular called pseudotumor cerebri, that is not migraine, but may look like migraine, but can be very dangerous because people can lose their vision. So, just making sure that this is still migraine. And then it's really important to let them know the truth that this is not working. This is not working. And if you're really not taking the medication, you got to tell them the truth that you haven't been taking the medication. It caused some kind of side effect that you weren't happy with, or it wasn't working, because there are doses that people can adjust to make the medications work better. There are switching that people can do to make medications work better, and then combining acute treatments with preventive treatments and lifestyle factors. The thing really important to take home about migraine is that it oftentimes requires a lot of adjustments before getting that right regimen. Some people are very lucky, they don't ever need to see a neurologist, God bless you. But there are other people that they need some fine tweaking. And then there could be 2 years that your regimen was perfect, but then things stopped working.
Right. And I can speak from my own experience because Dr. Monteith is actually my doctor, and my medications wear off every 3 months, and I feel like I have to change them. So it's
You're gonna fire me in public?
Never. I wouldn't dream of it. I wouldn't be able to get an appointment with anyone else. It would take a year. Okay, so we really appreciate everyone being here this evening. I just want to ask Annikah and Grace, do you have anything else any last thoughts you want to add in? And
I did.
Okay.
I did. I have just one comment. And Dr. Monteith touched on this. I just wanted to encourage those who may be living with migraine, regardless of and headache, migraine and headache, regardless of your diagnosis, and those who have loved ones who live with this disease. It can be very debilitating. I mentioned just a snippet of my experience for almost a year of not being able to do anything, and it can definitely feel like life is over. It can feel like there's nothing else, nothing's working, going back and forth with medications. It can feel like that. I do want to encourage everyone that lives with this that you can live with migraine. You can. Migraine does not have to be your life. So we've talked a lot in the migraine community. We've talked about how the language we use, and using language saying a person, like I'm a person who lives with migraine, because it does not have to be our whole life. It can feel like that, but it's not the end of our existence. So I do want to encourage that no matter where you are in your journey, to just continue advocating for yourself and your loved ones and continue pushing, and not give up, because it can feel like you want to give up. So I did want to encourage you all. And if you can find a group, a support group, there's a number. It will definitely change. It changed my life, being able to be part of a community of people. I have support outside of the community, but it's different when you are being supported by people who live with the condition that you live with. And so I encourage you, if you are able to, join a support group, because it will definitely have a positive impact. And so I thank you all and we just posted a link, at least for those groups supported by Miles for Migraine. If you would like to take a look. And there's also other events we have on the Miles for Migraine page, education events, walk, run, relax events, different things like that. So just take a moment and peruse the page. And we'd love to at least be here as an organization to support you and your loved ones. And I thank everyone so much for coming out tonight and being part of our discussion.
Thank you, everyone, and thank you to our fabulous panel for being here this evening. We're very grateful. Good night, everyone.
Good night.
See you at one of our events in person.